Okay. So good morning or good evening, everyone, wherever you are. Ladies and gentlemen, welcome to this exciting panel session on engaging stakeholders to turn research into policy amid political change. So in this session together, we will present experiences of primary healthcare programs in using similar strategies to engage key stakeholders in policy design and implementation research in two countries, namely Guinea and Ghana, and we will draw lessons for strategies in a similar context. We are together for 2 hours of exchange. Let us start by introducing our panelists. And before that, I want to acknowledge that this panel is supported by the Health Systems Strengthening Accelerator project, and the project is funded by the USAID and implemented by Research for Development. We also thank the partners of this NGO, Health Strategy and Delivery Foundation, ICF, and also the Bill and Melinda Gates Foundation. So this being said, I want to start introducing the panelists, but I would like to mention that you have access to translation services. Okay? And you can choose French or English, depending on which language you want to follow the panel on. Okay. So my name is Alexandra Delamou, and I am full professor of public health at the University of Conakry in Guinea, that is in West Africa. I will be the moderator for today's panel. And I now want to pass on to my other colleagues for their presentation. Over to you, Dr. Ama. Dr. Ama?
Hello, everyone. I'm Ama Penny, and I'm happy to be here. Thanks.
Thank you, Dr. Ama. Dr. Alphonse, over to you.
Hi, good afternoon, everyone. So I am Dr. Alphonse Makafri-Japasu. I'm a medical doctor. I've been working in Ghana since, and I'm actually one of the main key implementers of the primary care networks in Ghana. Currently, I'm a medical director of one of the district hospitals in Ghana. Thank you, over.
Thank you, Dr. Alphonse. We have Dr. Gumu, who is one of our presenters. Is Dr. Gumu, over to you if you are online.
Dr. Gumu is joining as a panelist.
Okay. Dr. Gumu will probably join later. I don't see him online. Okay, so I will pass to Dr. Andrews.
Yes, Dr. Andrews Ayim of Ghana. I'm a Deputy Director Policy in charge of implementing the network of practice policy in the country. Thank you. Over.
Thank you, Dr. Andrews. Dr. Matthias.
Hello, everyone. I'm Dr. Godi Matthias. I'm a medical doctor, a public health specialist, and I'm actually a maternal and sexual research assistant at the Centre National de Formation et de Recherche en Santé Rurale. This is a research center in Guinea, and I'm also a junior consultant on the implementation research in Guinea. Thank you. Over to you.
Thank you, Dr. Matthias. Okay, so as I was mentioned, mentioning, our panel will discuss the importance of using implementation research and engaging decision makers to improve policy design and effectiveness across different settings. I propose that we start by engaging ourselves through a short poll, which will consist of 2 questions. I'm handing over to Sarah to launch the poll, and we will meet later. Over to you, Sarah.
It's Joanna here. I will be launching the poll.
Ah, okay. Okay, so we invite everyone to cast their poll, to vote. Donc, nous invitons tous les collègues en ligne à voter pour cette première question. Okay. Are we okay with the poll?
People are still answering the poll.
Okay, great.
I think we can end the poll.
So we have about 87% participation if you're ready to publish the results.
Yes. Okay. Great. So the first question asks if you have worked on any of the following, and then I think our participants, half of our participants have already worked on implementation research. And this is followed by primary health care and community health programs for 41%. And few of our participants have taken part in developing national level policies. Okay, so I think that our participants are very familiar with the topic that we will be discussing today, which has to do with implementation research and the use of the findings from implementation research to improve programs at the community level. So that is great. So again, welcome everyone, and thank you to our panelists for their time to join this panel. So to start, I want us to think of our different political and economic contexts in which public and private actors are working to improve the health of our communities. I think we all agree that since the Alma-Ata Declaration, there is a growing evidence of the importance to focus on community health for health system strengthening. But on the other hand, we acknowledge that policies and programs that are designed at the national level may have varied degree of implementation at the subnational or at the grassroots level. Therefore, it seems very important to observe and also to study how the political environment, the political context can affect the policy reform, but also the implementation process. So today we will discuss experiences in Guinea and in Ghana, two countries from West Africa. In Guinea, the community health strategy was adopted in 2017 and was implemented step by step across the country. We are going to discuss in what context the policy was implemented, how the community and stakeholders were involved at the design stage, and the different stages of implementation research through a co-creation approach, and what are the preliminary impacts of the policy on the availability and use of health services. In Ghana, we are going to discuss an innovative model of delivering community level services, which is called the networks of practice. This initiative started almost 7 years ago and was modified in design and implementation multiple times to keep up with Ghana changing policy environment, political, climate, and health system priorities. We will also discuss the recent implementation research that was conducted to explore how this initiative can promote equity in health service use. I am now pleased to turn the discussion over to my colleague, Dr. Gumu from Guinea. Dr. Gumu is from the Ministry of Health. Dr. Gumu, I'm going to shift in French for you and ask our colleagues to use the English channel for those who need translation. Alors, Dr. Gumu, bienvenue à ce panel. Est-ce que vous pouvez nous décrire les principaux défis de la santé communautaire en Guinée et comment vous, en tant que responsable et leader au niveau de la direction de la santé communautaire et de la médecine traditionnelle au niveau du ministère de la Santé, comment vous avez travaillé avec l'équipe de recherche pour pouvoir prioriser les questions de recherche, mais aussi le défi, donc le type d'étude qui a été mise en place. À vous, Dr. Gumu.
Ok, merci, professeur Alexandre. Bonjour à tous. Je suis le Dr. Gumu de la Direction de la santé communautaire de la médecine traditionnelle de Guinée. Et effectivement, la Guinée est un pays de l'Afrique de l'Ouest, comme vous avez dit tantôt. Nous avons effectivement collaboré avec l'équipe de Accelerator dans le cadre du suivi de la mise en œuvre de la santé communautaire en Guinée. Pour rappel, la santé communautaire s'est inspirée des normes internationales et elle a été mise en place à partir de juillet 2016 parce que simplement on venait de sortir de la lutte contre la maladie à virus Ebola où nous avons beaucoup sollicité et utilisé le niveau communautaire. De là, l'importance de la santé communautaire a été initiée dans le pays. Et alors, une politique a été élaborée, suivie d'un plan stratégique. En Guinée, le système de santé communautaire repose sur le niveau suivant. Vous avez le niveau des communautés, les villages, dans lesquels vous avez des relais communautaires qui sont à leur tour supervisés par des agents de santé communautaire. Et tous ces agents de santé communautaire, relais communautaires, sont reliés et supervisés par un chef de centre qui est au niveau du centre de santé. Voici un peu le système basique de la Guinée. Un peu en haut, vous avez le district sanitaire que nous appelons chez nous préfecture. Et un peu plus haut, vous avez les régions. Et après les régions, vous avez le niveau national. Donc, quand je reviens à la collaboration avec le groupe accélérateur, effectivement, on a reçu l'appui du groupe accélérateur sur plusieurs plans. D'abord, dans la coordination de nos différents meetings, nos différentes réunions. Ainsi, nous avons tenu plusieurs réunions avec cette équipe pour ensemble définir les priorités. Un groupe a été conçu et ce groupe a travaillé sur un processus que nous avons dénommé processus de co-création. Le processus de co-création avait regroupé toutes les parties prenantes dont je venais de citer par niveau central, niveau régional, niveau préfecture, niveau sous-préfecture, qui ensemble ont tous travaillé ensemble en réunion. Parfois on tenait les réunions en ligne, comme ce que nous faisons maintenant. Parfois c'était en présentiel, pour ensemble, puisque la politique a été mise en œuvre depuis 2018, il fallait voir quel impact la politique a produit depuis sa mise en œuvre. Ainsi, avec L4D, nous avons mis en place 3 sortes de groupes de travail. Et pour rappel, ce travail s'aligne effectivement sur le plan stratégique de la santé communautaire avec 2 rubriques fondamentales. La première rubrique, c'était que les ressources financières qui sont destinées à la santé communautaire, est-ce qu'elles sont mises en œuvre comme décrit dans le plan? Et la deuxième rubrique, est-ce que le paquet en matière de services rendus au niveau communautaire, est-ce que ce paquet répond aux besoins de la communauté? Donc, ce sont les 2 questions fondamentales, les 2 domaines dans lesquels on a sollicité vraiment l'aide du groupe pour nous appuyer. Ainsi, nos travaux ont abouti à concevoir un certain nombre d'activités. On les a arrangées en 3. La première activité, c'était de faire ce processus de co-création qui a conçu à la mise en place de 3 groupes de thématiques. Un groupe qui va travailler sur le financement, comment le financement de la santé communautaire est fait. Un groupe a travaillé sur les rôles et responsabilités des parties prenantes, c'est-à-dire que tous ceux qui interviennent dans la santé communautaire, quels sont leurs rôles, niveau par niveau, jusqu'au niveau de la communauté. Et maintenant, le dernier groupe a travaillé sur l'apprentissage, c'est-à-dire la recherche. Justement, c'est à ce dernier point d'apprentissage de recherche où le travail a été très ardu et on a essayé de concevoir des outils essentiels pour nous permettre de voir à travers les recherches qu'est-ce que la politique a produit en matière de résultats pour le pays. Pour des consignes qu'on a eu à donner aux différents groupes, il s'agissait d'aller d'abord sur les attentes voire formuler des hypothèses et formuler des questions de recherche, suivi des activités et déterminer les responsables des activités et, si possible, indiquer les ressources qu'il faut allouer à ces différents. Donc, c'était une sorte de canevas de travail qu'on a donné à ces différents groupes. Donc, on a donné à ces différents groupes le document, le plan stratégique de la santé communautaire. Ils devaient identifier les causes profondes de ces différents défis qu'on a énumérés, financement, rôle et stabilité et la recherche. Ils devaient déterminer les causes profondes et puis ensuite développer un plan d'action pour résoudre ces différents problèmes. Ainsi, c'est là où la recherche est ressortie comme un point fondamental. Parmi toutes les différentes activités, il fallait voir au niveau de la recherche. D'abord, voir, parce qu'il n'y a pas une institution de recherche fondamentale où, là où la politique est déployée, qu'on puisse avoir les résultats probants de ce déploiement. On a eu des recherches qui ont concerné 2 districts sanitaires, mais on voulait avoir une recherche qui couvre tout le pays. C'est en cela que l'Accélérateur a été sollicité et nous ont répondu. Et il s'agissait maintenant de trouver quelle institution qui peut nous aider à aller dans cette recherche-là. Ainsi, on a mis vraiment à contribution toutes les parties prenantes pour qu'on ait un protocole de recherche et trouver d'abord l'institution qui peut nous aider. C'est en cela que l'Institut de Mafraya, l'Université de Conakry, en tout cas, toutes les institutions qui sont crédibles en matière de recherche ont été sollicitées et le groupe accélérateur nous a aidés à identifier ces différents points. Alors, quand nous allons dans la recherche, qu'est-ce que nous avions besoin? On a quand même estimé nos besoins en matière de questions de recherche qu'on a soumis et qu'on avait besoin d'avoir des réponses après la recherche. Il devait avoir une identification des questions de recherche autour de la mise en œuvre de la politique de santé communautaire. Nous avons juste formulé 3 grandes questions. La première, dans quelle mesure les acteurs publics locaux connaissent leur rôle et responsabilités dans le cadre de la mise en œuvre de la politique sanitaire et santé communautaire? Est-ce qu'il y a des facteurs qui entravent, qui empêchent qu'ils soient mis en œuvre? Ça, c'est la première question qu'on devait répondre. La deuxième question, dans quelle mesure les activités planifiées par les agents répondent aux besoins de la population jusqu'au niveau communautaire? Et la troisième question, dans quelle mesure cette prestation correspond réellement aux besoins de la population? C'est-à-dire, est-ce que ça s'aligne aux besoins que la population exprime au niveau communautaire? Donc, c'est en ce moment que des propositions, des pistes de solutions ont été élaborées. Et on a pris contact avec les institutions qui pouvaient nous aider à élaborer ces différents types de questions. Je pense que le docteur Mathias, étant dans l'appel, pourra nous donner un peu les résultats auxquels ces recherches ont été abouties. Donc, ce que je peux dire ici, c'est qu'en Guinée, tout le monde a adhéré au déploiement de la politique nationale de santé communautaire parce qu'on voulait que les communautés aient l'accès facile aux soins, aux prestations de services. Quand même, on a organisé des supervisions et les résultats de ces différentes recherches dont je venais de parler nous permettent d'énumérer quelques défis. Notamment chez nous, l'État n'a pas encore pris en charge les salaires de ces acteurs au niveau communautaire. Ça, c'est un défi majeur que nous avons et nous sollicitons par tous les moyens les partenaires à nous appuyer pour ça. Le processus de co-création a joué vraiment un rôle fondamental puisque ça a permis de regrouper toutes les parties prenantes pour l'identification des questions prioritaires. Donc, avec ça, je pense que si RD4 et Accélérateur continuent l'appui auprès du ministère de la Santé, vraiment, nous pourrons atteindre nos objectifs vraiment pour que nos communautés puissent bénéficier des soins de qualité. Alors, je reste quand même disponible pour toutes les questions d'éclaircissement et c'est en cela que je vous remercie.
Ok, merci beaucoup, Dr Goumou. Donc, vous restez en ligne pour plus tard. Je suis sûr qu'il y aura beaucoup de questions à votre endroit. So thank you very much, Dr. Goumou, for this important insight. I think you have emphasized the importance of the co-creation approach, which involves stakeholders from various backgrounds and help to prioritize the research questions that are very relevant for the Minister of Health, but also for community actors. So now let us hear from our colleague, Dr. Matthias. Dr. Matthias, you were part of the research team that conducted this implementation research on the community health strategy in Guinea. Can you tell us about the research design and the quantitative findings of this research?
Juste, docteur Delamou, si je peux me permettre, je ne sais pas si vous faites les questions à la fin de la séance, mais il y a une personne qui avait la main levée pendant l'intervention de docteur Goumou.
Oui, les questions, on le fera à la fin pour
Ok,
faciliter un peu le flow, quoi.
Ok, parfait, merci.
Ok. Ok. So, Dr. Matthias, over to you.
Yeah, thank you, Professor Alexandre. Thank you, Dr. Goumou, for this brilliant description of the community health policy context in Guinea and how we got to the implementation research in Guinea, entitled Community Health Policy in Guinea, a sequential method study using decision space analysis. A quick reminder of contextual factors, some contextual factors. Over the past decade, the government of Guinea has taken steps to move from a centrally and nationally directed and managed health system to one where power, decision-making, financing, and other important factors were decentralized to different administrative level of the health system. That's the regional, district, community level. These changes have taken the form of national level policy and strategies that aim to improve health services and health outcomes in Guinea through decentralization practices. As Dr. Goumou was saying, in 2017, the new National Community Health Policy that adds significantly to community health system decentralization movement by transferring responsibilities and competencies to the municipal level was adopted and implemented. To date, many financial and technical partners have been involved in supporting the Guinean government to implement and expand this new policy. As of January 2021, up to 257 communes were involved in this policy, out of 343. So just like Dr. Goumou was saying, a few studies have been conducted in the field to see how this policy have been implemented, what is the level of knowledge of community actors of their attributions and how they are implementing these attributions, and also what have been the perceptions of the impact of this policy on the routine services, maternal and child health routine services, and also what is the real effect of this policy on this maternal and child health indicators. So the overall aim of this implementation research is to explore the rollout of the community health policy in Guinea in the context of decentralization policies and the role of decision space in explaining gaps between policies implementation and actual implementation. So we explored two main research questions that were introduced by Dr. Goumou. And for this research, we used, a quantitative and a qualitative approach, so a mixed method. And that was a sequential mix method. To date, we have implemented the quantitative component, and we are moving now toward the qualitative component. So this research involved 27 communes that were shared between the three types of commune. Actually, in Guinea, we have communes that are implemented both decentralization and community health policy. We have that we used to call commune de convergence, excuse me, and we have a second category of communes that are implementing only the community health policy that we call ordinary commune implementing the policy, and we have a commune that are neither implementing the decentralization and the community health policy. So we sampled 27 rural communes among these three types of communes. And in these communes and at the district and regions level, we interviewed up to 537 respondents divided between the national level, where we have the ministries and the technical and financial partners. We have also the NGOs, and at the district level, we have the head of the health district and the head of regions. And at the community level, we have community actors and community health workers and RECO, who are the implementers of the policy at the community level. So for the selection of the regions to participate in this study, we used different indicators from the demographic and health survey in Guinea, the most recent one, and data from the National Statistics Institute. And we looked at the regions that had similar indicators, and among this region, we chose one. And by the end, over 8 regions, among 8 regions, we selected 4 regions. And in these regions, we selected 2 districts per region, and then community 7 rural communes in this district. So, like I was saying, at this stage, we have implemented the quantitative component. And for our data analysis, we use different approaches. We use descriptive analysis, linear regression, and time series to look at the level of knowledge and implementation level, but also at the impact of the policy on the maternal and child health indicators in our context. So what are the main findings of this quantitative components of the implementation research in Guinea? Our first study objective was to look at the level of knowledge of the different actors with the policy and the possession also of the policy documents. Overall, our results show that actors at all levels had a low level of knowledge about policy documents and strategies related to community health and decentralization. Similarly, the majority of actors did not have these various documents. The state of affairs constitutes a major challenge to harmonize implementation of community policy without decentralization. Knowledge of and possession of policy documents and strategy related to community health and consideration of their content by actors would promote better ownership and attributions, better coordination of activities, and harmonized implementation of tasks. An evaluation of USAID high quality services for development project in Guinea in 2022 found that community health workers provided services that are inconsistent and variable across the region. With regards to the knowledge of the local public actors of their attribution within the framework of implementation of the community health policy, but also the implementation of this attribution, the result of the study showed that the actors at the central level had a relatively good level of knowledge, but suboptimal given the challenges of community health policy. community actors generally had low level of knowledge about their duties, and this result were similar in the three types of communes. On the other hand, the community health workers and the community RICO had a relatively higher level of knowledge of their duties. The low knowledge of the national and community level actors could be partly linked to their low level of knowledge and possession of documents related to the community health policy and decentralization. For the community health workers, on the other hand, the result observed could be the translation of the training curriculum, which includes activity assigned to all community health workers and RICO, even outside the community health policy and decentralization. Compared to the implementation of recognized attribution, central level actors and community actors were little involved in the implementation of their attribution, unlike community health workers and RICO, who had demonstrated greater involvement in the implementation of their attribution, their main responsibility with the framework of community health policy. Our result also showed that actors at the municipality, at the community level, had better training in the development of a strategic plan or an operational plan compared to actors at the district and regional level. This could be explained by the fact that community actors are regularly involved in the preparation of local development plan with the support of the Ministry of Territorial Administration and Decentralization and its partners. It should be noted that the rate of possession of the national and regional financial budgetary management manual was higher among actors at the community level, up to 95%, compared to at the district and regional level, 60%. In addition, about out of 10 regional district level actors reported that they were not involved in the management of community health policy funds. This means that there is either a centralized management of this fund, which does not sufficiently involve regional and district level actors, or there is non-transparent management of the policy resources, even in the district which are home of the convergence communes. It is important to emphasize that the capacity building of community health policies actors at the regional and district level, particularly is strategic planning, has implications for the successful implementation of monitoring of activities through specific indicators and the sustainability of activities acquired from the policy in the commune and district concerned. This study also demonstrated a low level of involvement of higher level actors in monitoring the implementation of the policy activities. Generally, formative supervision is an essential component of implementation of any program or project in accordance with the basic objective. The low level of involvement of policy implementation actors in the supervision of community health workers and RICO within the framework of the community policy is partly responsible of the observation made on the effects of the policy on the maternal and child health indicators in the communes of implementation. The factors that hindered the implementation of community health policy, actors of their official attribution, were mainly related to the capacity of latter to implement them. Among these factors, we can list the low level of knowledge on role and responsibilities, the low level of knowledge and the low availability of administrative and financial management procedures. So at this stage, I'm going quickly to summarize the rest of the main findings we had. In terms of effect of the policy on maternal and child health indicators, we found that when we aggregate the data, the policy had an impact on maternal indicators in the communes of convergence, the commune that implement both community health and decentralization, but not in the commune that implement only community health and the commune that neither implement the both strategies. When we look at communes level, we understood that the communes were different in terms of impact or effect of the policy. And there was also communes that were not part of the convergence commune who were also experiencing good improvement of the different indicators, I mean maternal and child health indicators. This means that there is issues related to the implementation of the policy in terms of knowledge, in terms of implementation of the attributions that are having a kind of impact on the effects, I mean, are having a kind of impact on the maternal and child health indicators across the different communes. So it's at this stage, we have summarized, I mean, listed some hypotheses to explain the different results we have got at this stage, and that we are going to explore during the qualitative component. So I'm going to hand over to Prof. Alex for the next step. Thank you.
Okay, thank you very much, Dr. Matthias. I want to remind all our guest participants that we will have a question and answer section at the end of the presentations. And you can now write down your questions in the chat. We will collect them, and we will also give the opportunity for those who want to speak at the end of the presentations. So thank you very much, Matthias. You have noted that the impact of the policy from a quantitative point of view has varied across regions and even within the regions. Also that there are several gaps that justify conducting the qualitative component of your research. Now I want us to turn to our colleagues from Ghana to learn more about how they have used research, mainly implementation research, to adapt their flagship program for a nationwide scale-up. So my first guest for that will be Dr. Andrews. Dr. Andrews, please, can you tell us a bit more about the networks of practice, how it has evolved, and what role has research played in this evolution in Ghana? Over to you, Dr. Andrews.
Yes, thank you very much, and good afternoon, everybody. Yes, you know, Ghana has been committed to the primary healthcare since 1978 with the Alma Ata Declaration. In fact, Ghana was the first country to send a blueprint because at the time we were shifting away from hospitals into the community so that we get health closer to the people. So this commitment was further emphasized with the United UHC for 2030. So when we did our UHC roadmap for 2030, and believe that the primary healthcare system should lead the health system in Ghana. But the primary healthcare was made up of the district, the sub-district, and the community. Now at the district level, we have the hospitals and the district health directories. And in the community, we have developed the CHIPS compound also from an implementation research on how community health nurses staying in the community was better than if they go and come. So we created CHIPS compound where community health workers were staying in the community and were staying with the people and were doing a lot of health promotion activities with minor ailments management. But the health center over the 2 decades was forgotten and left out. So in the end, we saw that we have strengthened the community, but then the health centers were weak to receive the referral systems at that level. So most of the referrals were going to the district hospitals. So then the gatekeeper system was broken down. So we decided to look at how to deal with that issue where the health centers were the weakest link in the primary healthcare system at the community level. And that is how come in 2015, then the concept came up that then the experiment should be done. And that is where the implementation research was done, so that at that time, the National Health Insurance and all the other groups, the Ghana Health Service, the Ministry of Health, with technical assistance from USAID and Systems for Health, came together to create an implementation research work in a region where they will create in 2 districts, 1 region, 2 districts, where they will create 10 networks, which they created, and then using 42 facilities. And what they did was to create that network at the time. It was called Preferred Primary Care Provider Network. And this was commissioned to test how, when facilities form networks, they can work together. In the end, we saw that the network meetings and monthly reporting systems had improved, community mobilization had improved, clinical outreach sessions had improved them, and the monthly review of the National Health Insurance claims report at that level had improved. In fact, one of the facilities was able to improve the claims rejection, because when they send the claims to the National Health Insurance, sometimes there were a lot of problems and errors with it. But when they came together and added all their strengths together to support each other, they had reduced their rejection rate by 69%. So the networks, we saw that at the policy level, we realized that then it could answer our questions in terms of how to improve collaboration at that level, because at the time, whenever patients are referred, sometimes they fall through the cracks because they don't have resources to go to the district hospital, and the health centers were also very weak. Then they kind of, they don't get anywhere to go. So they end up falling through the cracks. So that is why we looked at the results of this implementation research that was actually done between the 2017 and 2019. So when we looked at it, then we decided that then let's form the policy of the network of practice. Already we've had the spokes, which was the hubs and spokes model. The spokes were the CHIPS compound and the health centers are the hubs. So now some of the regions like Volta region, already they are getting support to start to work on it. And when we visited them, and I think Dr. Alphonse will speak directly to that, they were doing very well now with the gatekeeper system, where the health centers have been strengthened with human resource, with equipment. And therefore, when there's a referral from the CHIPS level, which is the lowest level, the community level, they have a place to go to before they get to the district hospital. And therefore, health is closer to the people. We are now going around to work on it to see how many networks the regional directors can form to reach that level where we want to go to. But so far, with the various places that we've been, and the regional directors have agreed and adopted it. This particular policy, the interesting thing about the policy was that it was a bottom-up policy strategy. So the bottom-up policy strategy, we are working with the people, and it's what they are doing that we are writing as the guideline. So now we are not writing like initially we write and then we send the documents to them. Now we are going to them, and what they are doing is what we are writing as the policy. So we are still writing as the policy. We are still writing it, and then that's what we are doing, and we are going around looking at what they are doing. So far, it's been very, very, very good in terms of how they are working together. Now, when it comes to the implementation research, where they chose and how the work was, in the end, there was a lot of benefits that they recorded from the implementation research, because naturally, when it comes to policies, we've come to realize that whenever you don't put the policy among human beings or among people, you don't get the complexity of implementation. But when we put it among people and people start reacting to the policy, then we begin to get the various dimensions. And one of the dimensions that the people wanted was quality. And if they perceive the health centers as quality, then they will go there. But if they don't perceive it, and the factors for perceiving a hospital or a health center as quality was to see the personnel who were there, to see the equipment who were there, and then to get the testimony or the discussion of the clients when they go back to the community to describe what service they received there. And this is what has made us in the policy department decided that we are going to, we are trying to lift the health centers into something we call the model health centers, where they can meet the customer satisfaction of the community, so that then the community will agree that we will no more travel to the district hospital, but we'll come to the health center. The other thing we are seeing, and is very good, was that initially we were thinking the community wanted to own the facility, so that when they are in a network and there's one spokes, there may be community disagreements. But we've seen that in practice, the implementation research showed that the community were ready. Once there was quality, they were ready to go. And once they believed the human resource was quality, the equipment was quality, they didn't mind all being in a network to moving. The other thing we noticed was that now the partners are ready to fund the network and not individual facilities or individual send one equipment to this individual facility, but now they want to support the whole network. And already we have some of our partners supporting some of the networks. And in fact, they've even supported it to link up with the hospitals with teleconsultation systems, where now at the health center level, the physician assistant is able to call the doctor, discuss the issue, so that the person may not need to go to the district hospital to do that. So this is how we have looked at it, and the experiment that showed the benefits of increased collaboration, increased teamwork, and the relationships that was empowered. Network members were able to exchange knowledge and skills, and networks have developed means of accountability, joint planning and administration, and the quality of service delivery among the network is gradually improving. And commitment from networks and network leads have become strong, because now the leader is a leader over a network and not just one facility. And so the responsibility has gone up. And we've seen that looking at all the additional districts that were added, the potential for sustainability has gone up. Thank you very much, and over.
Great, thank you very much, Dr. Andrews, for these insights. And we understand that, as you mentioned, a bottom-up strategy works better than a top-up one. And we also learned that flexibility and adaptability have guided the pathway of these networks of practice. So we want to learn more, and now we are moving to Dr. Ama. Dr. Ama, please, can you walk us through the most recent implementation research that was done by your team, and what are some key findings? And can you also tell us how you worked with the practitioners to design and implement this study? Over to you, Dr. Ama.
Thank you very much for this opportunity to present what we've done so far. So for the implementation research, it was on leaving no one behind, the role of PCP networks in promoting equitable UHC. This was conducted primarily to understand the role of this innovative model we had, which was the PCP networks at that time, now the networks of practice, in advancing equity. And here we were concentrating on the poor, women and people who lived in rural areas and what we call hard to reach areas. And the study used mixed methods. We used both quantitative and qualitative research methods. And this was conducted in the Volta region, where the PCP networks had been piloted in 2 districts, South Dai and South Tone districts. one of the things I must say is that right from the beginning of the implementation research, we were working with our practitioners and our implementers on the research tools. They were from the ethical proposal through to the development of the questionnaires. We had worked hand in hand with them. And so they were part of this process. The quantitative results show that although a lot of the people we had interviewed, a lot of the individuals in the households we had interviewed sought care when they were ill, many of them were bypassing the lower level facilities, which is what this whole network of practice was about. They would bypass these lower level facilities, especially in the rural areas and among the poorer households. And this raised issues around equity, because these are the main reasons why the PCP networks have been established. They would travel longer distances because the higher level facilities were very far away from their houses. And the question was, why were they bypassing these lower level facilities? And one of the factors that drove this issue was health insurance status. So what we realized is that from the quantitative results, the households that had health insurance were more likely to use facilities that allowed them to use a health insurance card. And most of the lower level facilities at that time were not credentialed, and so they could not accept households who had the health insurance card. Another reason that we got from the qualitative research that helped us to understand further why they were bypassing these lower level facilities was the issues that have been raised by Dr. Enim, issues that revolve around supply side challenges, such as the availability of drugs, supplies, infrastructure at the lower level facilities, which really made it difficult for them to appreciate that these were facilities they could go to. So at the end of the day, quality was an issue. And there were other specific community factors that also made it very challenging for these households to use the health facilities. For example, we had, through the qualitative results, we were told by some of the key informants that transportation was a big problem, especially in the rural areas. And I know most of us are very familiar with this as a big bottleneck when it comes to people in very hard to reach areas getting into our facility. So transportation was a big problem. And it lends the fact that some of these health issues are really not specific to the health sector and go beyond the health sector to many other broader sectors that we need to look at. And that is what we got from this study. I must also note here that during the validation workshop, when we went back to report to our, we sat together with our practitioners and the managers of the lower level facilities and the members of the hub, really, to understand how we could address some of these problems, how we could make sure that the networks of practice were actually enhancing equity and not driving people away from the health facilities, especially at the lower levels. And it was clear from our discussions with them that we really needed to engage more with our communities. We needed to engage more with the local government and also engage with the private sector to solve some of these barriers that we had encountered, and that the recommendations that we came up from the study were recommendations that were co-created with our practitioners in the study districts. And I must say that some of these recommendations have been mentioned by Dr. The expansion of the networks of practice and model health centers that help, so now it's actually bringing all facilities where we also made a recommendation that I must mention here, that we should continue implementation research to further the security aspects of the study. And one of the recommendations was to have implementation. We would be working hand in hand with our practitioners to understand how these PCP networks will operate and be successful. And that has been achieved with funding from our partners. We've been able to go on to do a second phase of this implementation research, which is ongoing as we speak. And this second phase of the research is actually going to collect baseline information from 2 districts that to have the networks of practice pilot. When we did the results that we had was attribute some of the successes. So now we have a very good baseline, and we are hoping that subsequent implementation research will be carried out so that we can start making some solid attribution to the impact of the networks of practice on some of our key health indicators in the districts that are going to have them rolled out. So these are some of the lessons we've learned from previous implementation research. And we know that as we continue to institutionalize this, it will benefit all of us in the health sector and beyond. Thank you very much.
Okay, great. Thank you so much, Dr. Ama. I think we have learned from your presentation that mixed methods are good methods to explore issues that are related to equity in community, and also that we need more engagement with the community, local government, practitioners, and the private sector, and the solutions should be co-created. That's very important. Also, implementation research is a continuous process. If you want to assess the impact or the process of policies and strategies. Thank you very much for that. So now we are moving to Dr. Alphonse. Dr. Alphonse, you are the actual implementer of the initiative. We have been discussing the network of practice. You were also engaged in the implementation research. So I want to ask you, first of all, can you talk to us about the journey of this network?
All right, thank you very much, Dr. Alex. Good afternoon, good morning, good evening to us all, wherever we are listening from. Thank you for the opportunity. It's always a happy moment to share highlights on the network of practice, now network of practice, which initially was primary PPP, which was preferred primary provider, which later became primary care provider. It started as a small discussion, as Dr. Yim said, and now it has grown up to become a big discussion, not just within some few people in the ministry, but across the whole country. And the aim of this is that it should help us to achieve universal health coverage. So as was said earlier, somewhere 2015, 2017, the National Health Insurance, Ministry of Health, with some other agencies, did some work on Ghana's healthcare system, just to understand how services are rendered. When this was done, it was realized that it was done in 3 regions. Then we had 10 regions in Ghana. When this work was done, it was realized that there was a big gap, especially in service delivery, a very, very big gap. So how best was it supposed to close the gap? The best way to close the gap was group working or networking. That was the best way to close the gap. They realized that most of the facilities, which was 56% of them, were all CHIPS compound. And CHIPS compound, as Dr. Yim explained, we have the districts, sub-districts, and the community. The CHIPS compounds are the list of facilities. So the packages of services, the human resource, the logistics, especially the drugs and the non-consumables. And in addition, the infrastructure was a major problem. So they couldn't deliver the healthcare as they had to. So they went into this grouping, and this led to the formation of the networks. So as I said initially, it was called the Preferred Primary Care Provider Networks, which was more of a health financing strategy, which had three main objectives. The first objective was service delivery. The second objective was organization and management, and the third was on financing and payments. But after the 1 to 2 years of implementation of then the PPP, they realized that the service delivery components really grew. Between the years 2018 and 2019, we realized that there was improved in the referral system, and this was in South Dine where I was practicing. There was improvement in the coordination of referrals, and when we were moving a case from the sub-district, the CHIPS compound, to the health center, to the hospital, there's a system you could call. We use the WhatsApp platform, you could send your messages and leave it on it. Then we could coordinate the referral system very, very well. So that led to improvements in the referral system. One thing it's also led to was improvements in the referral feedback, so that any case that was referred, you could get a feedback because it's a WhatsApp platform instantly, and it helped a lot with referral system. Then it also led to improvement in the skill delivery, within the district. Then also one thing we also realized that because of the coordination among the health facilities, as the CHIPS compound, health center, and the district hospitals, there were no under 5 malaria case fatality at all within the district. Within the same period of working together too, there was no maternal mortality, all because the referral system had improved. Cases were informed, referral centers were informed before cases were being sent, and that really helped a lot. So with these developments, the PPP was rebranded, I would say in 2019, 2020, it was rebranded from PPP to PCPN, and they focused more on service delivery along different aspects, especially with outreach services, how we could improve on immunization, skill delivery, how to reduce the influence of traditional birth attendants on childbearing, how to improve on reducing malaria case fatality. So we went a long way to do that. And now from 2019, 2020, now 2022, now we move from the primary care provider network to network of practice. As Dr. Yin said, this is our main policy strategy to achieve universal health coverage over the period. And as he said, it's a bottom-up approach. And from the implementation research, how we are using the findings from the recent study in developing the healthcare system. So from the implementation research, which was done in 2020, which I was a key member of, some few recommendations came up. And the recommendations, as has been enumerated by Dr. Amma, are very key points that we put into consideration when we did the scale up to other districts and other regions. Some of the key points she spoke about was community, involving the community, educate clients and communities about it, which was important, review implementation norms, designate a model health center. So in the way forward, we were like, how do we let implementation research guide our way of implementing the healthcare system and the healthcare strategy? So one main thing we realized was the problem was that the health centers, which were the hubs, actually didn't have certain logistics, didn't have the human resource, didn't have the equipment. So one main key was we agreed on the right mix of the human resource for each network. So if you take the health center, which is the hub, we needed to have clinical and non-clinical staff. We insisted there should be a physician assistant, should be a midwife, should be a registered nurse, should be a community health nurse, should be a lab tech account, so that if we want to maintain quality of care, so that we can maintain the gatekeeper system where people will not skip the health center and go to the district hospital, we needed this human resource there to render the package of services. One other thing that was agreed on was, and is being done, is that the equipment and logistics were needed. Certain basic equipment, if you are talking about the model health center or the hub, then you are talking about certain basic equipment like the BP apparatus, the autoclaves, all the things that you need to render the services within the community, so they have healthcare within the community. So from implementation guidelines, this thing came up and we started adding them on when we had to move to new districts. Then the model health center approach came in, and this one was being introduced, and we are looking at the maturity design concepts, where we are looking at where the health centers are now and say that we aspirationally within the next 2 to 3 years, we should be somewhere. But where we are now, we are saying there should be a basic mix of human resource, basic logistics, and basic medications that should make sure that people are receiving quality care within the community. Another thing from the implementation research is that we defined the package of services for the health centers, which are the hubs of the network. So within the network, you know the services you are supposed to receive, so that people will not skip the health centers and end up in a district hospital, which actually increases the cost of treatment and cost of receiving care for them. One thing that also came up is involving the other stakeholders. And I think in going up as an implementer, one thing we've done very well is to involve all other key stakeholders. We involve the district assembly, and district assembly at certain places has gone up here to build new health facilities. We've involved CHAG, which is the Christian Health Association of Ghana, and they are part of the networks. We've involved other faith-based organizations, private, and all this have come together to form stronger networks to improve on the quality of care for the people. In moving forward, community involvement was as came out to be a very strong point within implementation research we had to work on. So in building the new networks, the community was involved from day one. There was community sensitization, there was community mobilization, and one key strategy which was used was the community scorecard, which is an accountability tool, which the community was equally well educated on. And it's one thing which has helped the new networks that have been formed very well. And the community scorecards make them realize that they are part of the facilities. They assess the facility on 9 key points, draw an action plan, and see how best they can improve healthcare within their own networks. Some have gone ahead to build placenta pays for their facilities. They've gone ahead to clear facilities to make sure that facilities are safe, are provided security people. And it's a way of the community getting involved within the network. So they've come to appreciate their involvement in healthcare delivery. Another key part that came out with implementation research was looking at the functionality or the readiness of the hubs, which are like the center of the network, as was said by Dr. Yim, the hub and spoke approach. So the hubs need to be ready. So we looked at that keenly in going forward, so that we created a 5-step or a 5-approach system to value or to find the readiness of these hubs so they can render. And in doing this, we realized that most of the hubs are built up better than the initial ones, and they're able to render the care of the package of services that we expect them to render, so that the referral beyond the network to the district hospital is minimized over the period. And the data from the last annual review, which was done on the new networks that were formed, indicated that yes, more cases were managed within. Another thing that was keenly introduced also was the introduction of the teleconsultation and the telemedicine center. So we realized that one thing to improve healthcare was that if we had senior colleagues or expert colleagues at the other end, with the research showed, you could engage them. And when you engage them, they could give you some guidance from a distance, and then care and service can be rendered right within the community. So in a nutshell, to say that over the past 7 years, the network has gone through phases. We've gone through the phases of the preferred primary care provider network, where it was started in 2 districts, then was built up, then implementation research came with certain good recommendation, which has been added. And now we've gone beyond 2 districts. We've done 10 districts. We've formed over 42 networks, and the new networks that are being formed are better, are stronger, and are delivering the packages of services. And we are looking forward that as more second implementation research or more, as we are learning from the new ones that are being formed, the newer ones that will be formed will have a stronger ground, a stronger bearing to deliver quality of healthcare services with the introduction of the maturity system for the model health center, so that we have the model health center that grows through the phases. When we get to the former phase, then we know that we can receive quality of care within the network and within the community. So in a nutshell, this is the journey for the primary care provider now network of practice within the 7 years where we are now and where we hope to get to. Thank you, and over.
Great, thank you so much, Dr. Alphonse. Your presentation was great to help us understand that implementation research is not a direct line, but a back and forth process during which stakeholders work together, learn, improve, and adapt. You have shown that findings should be shared on a regular basis to support improvement on the long term. We also see that the network is expanding, but is still fueled by learnings from research. So I think we have been able to follow all the panelists that were scheduled today. Thank you so much for those insightful presentations. We are now set to move to the next stage of our webinar, which is the question and answers section. And we will be able to give the floor to participants. There are already many questions on the chat. So maybe I will start with a first question that is directed to Dr. Ama Feni. So Dr. Ama, the question is if transportation was a barrier, and why was hard to reach communities still bypassing the primary health units?
Okay, thank you very much. So I did put the answer, and I'll just sort of summarize it. The main reason was quality. Subsequently, we asked them that if they had an opportunity to go to any other facility apart from the one they chose, which one will they go to? And most of them preferred the higher level facilities. And the issue was because of the quality of services. And so they would rather go to a place where they would see a doctor, for example, where the facilities were better equipped, where drugs were available, and generally they would receive the kind of care they wanted. So they would sacrifice. And one of these things that cautions us is the fact that most of these households would wait for a number of days before they take that decision to go to that higher level facility. And so that we realize the importance of these networks to work so that households will not have to wait till the very last minute and have to travel those distances to get to the facilities they prefer. So this is the main reason. Thank you. Over.
Thank you, Dr. Ama. We have another question for Dr. Alphonse. So Dr. Alphonse, can you explain a little bit more on how you are sharing counter-referral information on referral cases on WhatsApp platforms? Of course, it's innovative and practical, but how are you securing patient data? And if any other challenges or consideration? Over to you.
Thank you very much for the question. So when it comes to referral, there were multiple ways of sending the information. The formal way we do is to have the referral booklets, which automatically comes with a referral feedback form. So for prompt referral, then we use the WhatsApp platform where information is dropped. One thing which was key and shared among us was patient privacy or patient right protection, as in protecting them. So we never added the patient's name. We always used abbreviations and their names and their ages. So if it's my name, like Alphonse Japasu, we won't put Alphonse Japasu, we'll put patient AD, male, 40 or 30 or 25 years there. Then we write the details. So if you have to reply, we take the same message and reply and say patient has arrived, patient is doing well, or patient has arrived, patient is in theater, patient has arrived, patient is being attended to. Then in writing the referral feedback, that is where we use the formal way, where we fill the feedback form and fill all the necessary documents and send. So the electronic way was to prompt the system. So I'll give you an example where a patient who was being referred from a facility which was 1.5 hours away from the hospital. So they send a message, patient JS, 29 years, female, is bleeding, and the HB checked is 4.5. We are referring, and UPT is positive. Obviously, with this one, we all thought it could be ectopic. So quickly, we activated theater, activated the whole emergency system. When the patient got, the patient was in shock. Quickly, emergency knew the patient was coming. So there was a team ready for the patient. Quickly gave fluids, sent the case to theater, Within 30 minutes, surgery has been done, patient was being transfused, patient was well. If it was before then, when we didn't have this WhatsApp platform, they will send the patient at your blind side, you have no idea. The emergency system might be there, but it might not be responsive enough. And the patient will go to theater and maybe the anesthetist may not be around, the doctor may be occupied with something. So you will waste more time attending to this patient. So sometimes 2 to 3 hours, something that could be done within 15. So we realized that helped a lot and helped to reduce our morbidity and mortalities. So patients' rights were protected by making sure their names were not used, but then initials were used. But the formal write-up, which they always use the form, we wrote the formal documents and everything on it. I hope that explains it. Thank you, over.
Okay, thank you, Dr. Alphonse. And now a question for Dr. Goumou. I will make it in French. Dr. Goumou, une question pour vous. Est-ce qu'il y a eu une fenêtre politique ou une volonté politique qui a conduit à l'adoption de la stratégie de santé communautaire dans votre pays?
Merci beaucoup pour l'intérêt accordé à cette question. Oui, effectivement, parce que, comme je vous ai dit, ça a ressorti à partir d'une leçon apprise sur la lutte contre la maladie à virus et Ebola, où l'importance du niveau communautaire a été révélée. Donc, vu l'importance de ces leçons apprises à la lutte contre la maladie à virus et Ebola, il était question de passer à la vitesse supérieure. Et on ne peut pas adopter une politique si les autorités ne sont pas fortement impliquées. Donc, une politique a été élaborée, elle a été validée. Et beaucoup de départements se sont engagés à accompagner la mise en œuvre de cette politique, notamment le ministère de l'administration du territoire et le ministère de la Santé, qui sont en quelque sorte les plus décentralisés possibles. C'est eux qui accompagnent le système jusqu'à la fin. Et d'autres ministères se sont insérés, les finances et maintenant l'enseignement technique vient d'emboîter le pas. Donc, ça a été vraiment une forte implication au niveau des autorités. Sinon, ça ne serait pas validé. Tous les documents normatifs ont été validés par les autorités compétentes. Merci. Vous m'avez entendu, j'espère.
Oui, oui. Alors, docteur Goumou, donc on vous garde encore. Je voulais savoir, est-ce que, sur la base de ce que vous avez dit, est-ce qu'il y a encore cette volonté politique qui existe pour continuer de soutenir la mise en œuvre ou alors l'amélioration de cette stratégie?
Oui, au jour d'aujourd'hui, le même engouement existe. L'handicap majeur, c'est ce que j'ai dit, c'est-à-dire la prise en charge des salaires des gens du niveau communautaire. Et Dieu merci, maintenant, là, il y a une nouvelle loi qui est en train de prévoir la prise en charge de ces acteurs. Donc, je pense que les choses vont être peut-être débloquées, mais l'engagement est là. Le ministère de l'enseignement technique vient de s'aligner maintenant, ça n'a même pas fait 3 mois. Donc, ça veut dire que l'engouement est d'intérêt national et on a vu que ce n'est pas le ministère de la Santé seul qui peut partir. Non, il faut composer avec tous les autres départements. C'est ce qui fait que les départements, dès qu'ils voient l'importance de l'action, ils sont là, ils adhèrent. Donc, et maintenant, c'est en train d'être intégré dans la nouvelle loi. Merci.
OK, merci beaucoup, Dr. Goumou. We have a question for Dr. Andrews. So, Dr. Andrews, what recommendations do you have for researchers who want to effectively disseminate their work and ensure it's useful for policy and program decisions?
Okay, thank you. I think it's important that before you do the research, you look at the strategic direction of the leadership of the country. I'm talking of political direction, because most of the time there's already the political direction, and then there's the Ministry of Health and Ghana Health Service, for instance, direction. Then the researches that are done within that framework are easily adapted by the system, because most of the time we are looking for those research to support some of the thinkings that had gone on, or to reject some of the thinking. So at that decision point, you need that supportive thing. But sometimes, because the research is funded by other interests, sometimes it's done in a different way, and therefore it is not easily adapted by our policy direction that we have. But generally, like now in Ghana, for instance, the network of practice is our strategic way. The universal health coverage is the way to go, and therefore the researchers can look at that, and then we will be very happy to adopt a lot of the work they do into our practice and policies. Thank you very much. Over.
Okay, thank you, Dr. Andrews. Dr. Matthias, from the Guinean perspective, do you have any comments on how to effectively disseminate findings in your context? Over.
Yes, thank you, Professor Alex. Yeah, actually, from what we have got, what we have got from our quantitative component, for instance, we are actually planning first to have a workshop, a validation workshop with the different stakeholders. Among these, we have the health system and also the health system financial and technical partners who will be part of this workshop. So we'll be able first to present the results of our study to get their feedback, because they are those who are involved in the implementation in the field. And then from this, they will also help to amend the different recommendation. So after the second component, of course, after this, we go to the second component of our study, that is the qualitative component. So after the qualitative component, we will write a final report, and we will disseminate this report through workshop and also publication at this stage, because we want more people outside of the country and in the country to get to know exactly what we have done and what is the result of the implementation experience, community health implementation experience in Guinea. At this stage, I would like to say that we have submitted now the protocol of our study that have been accepted for publication and will be soon, very soon published. And then the result of it, the study will be also submitted for publication. Over to you.
Okay, thank you, Dr. Matthias. I don't know if we can take colleagues who are online. I see that some have their hands on. I will turn to our host and co-host to see if that is possible or not.
Yes, Alex, I have allowed Eric can speak now.
Okay. So over to Eric.
Hi, thank you. So, no, I think thank you very much for the great presentation. I think it was just a mistake. No, I don't have a specific question. Thank you for presentation and recommendation. No.
Okay, or maybe you have any experience to share related to those presentations?
I don't have a specific experience to share. I think no. Thank you very much for presentation and recommendation.
Okay, thank you. Okay, so the floor is open. If we have participants who wants to reflect or who wants to ask questions, clarifications, you are most welcome. Okay. And I have a question for our colleagues from Guinea and also from Ghana. And maybe I will start with our colleagues from Ghana, Dr. Ama. So from your experience, how do you think international researchers can ensure that their work is context specific, and also how to best engage local stakeholders in this process?
Thank you very much for this. I must say that this question to me as an academic is very relevant, because many times we do a lot of research and then it ends up on the shelves because they are not really needed by our policymakers. And the question is, how do you get policymakers to appreciate the kind of research you've done? And this is what the implementation research we've done in Ghana and continue to do in Ghana has shown us, that if the evidence is needed, really when you do the research, the uptake is very, very immediate. It doesn't take too long to engage with your policymakers because they're part of the process. And that's the success of this implementation research, because we've worked right from the beginning with our practitioners and our implementers to develop the tool to appreciate the challenges of working in the terrain, and also to solve some of the problems ahead of the field. Your work is appreciated by those you are there to help, and they see the benefits of the evidence that will come out of the research, and you don't get that pushback, and they appreciate the effort that it takes to actually do the research, and that has been very, very influential in how much of this research has made an impact. And as we see, as Dr. Jakpasu said, they've learned from the recommendations that have come from the research, and we continue to see it helping in the expansion of the networks of practice. So I think this is a big step when it comes to moving academia into policy making and also implementation. And I think eventually we will write about this, the whole idea of co-creating our recommendations, that it alone has shown that it's possible to actually get policymakers to engage with researchers, and also to the uptake of the research at the end of the day. We have published something about co-creation, and I think as we continue to disseminate the findings of this research, more people will appreciate the importance of implementation research in the health sector and beyond. Thank you very much. Over.
Okay, thank you, Dr. Rama. So I will turn now to our Guinean colleague to also, so that they reflect also on this question. And I will speak in French. Dr. Goumou, donc on a aussi une question, hein, vous qui êtes au niveau du ministère de la Santé, et de votre point de vue, hein, de programme, gestionnaire de programme, et comment, à votre avis, les équipes de recherche peuvent s'assurer que leur travail est vraiment défini selon le contexte, et aussi comment vous voyez ou bien vous aimeriez que les chercheurs puissent engager ou impliquer les responsables des programmes dans le processus de recherche. À vous. Est-ce que Dr. Goumou est en ligne? Votre micro est fermé, Dr. Goumou?
Oui, j'étais en train de oui. OK. Bon, en fait, nous, je le mets en deux plans. Le premier plan, c'est d'abord le partage des résultats des recherches qui sont déjà effectuées. Et cela, les résultats vont prouver à suffisance que c'est nécessaire que toute mise en œuvre soit accompagnée par des recherches opérationnelles. Et pour nous, la place de la recherche a été révélée depuis les différents travaux effectués dans le processus de co-création. Ça nous a encore rassuré davantage qu'on ne peut pas développer une mise en œuvre, une politique, sans mettre à côté le domaine de la recherche. Donc, c'est fondamental pour nous. Alors, nous avons plusieurs programmes de santé au niveau du ministère, mais l'avantage de tous ces programmes, c'est que ça converge vers le centre de santé. Or, la mise en œuvre de la santé communautaire commence par le centre de santé. Donc, on a un endroit où tous les programmes vont se retrouver, c'est au niveau centre de santé où toutes les activités sont développées. Donc, on demanderait plutôt qu'il y ait un large éventail de questions qui prennent en compte les préoccupations des programmes de santé pour que la recherche soit de plus en plus inclusive, que ça intéresse tous ceux qui développent le domaine de santé au niveau communautaire. Donc voilà un peu la réflexion, mais on est vraiment sûr que la recherche est fondamentale dans nos processus.
Ok, merci beaucoup, Dr. Gumu. Do we have any question from participants? I do not see a hands up, so okay. So maybe I will come back to Dr. Andrews, because with your extensive experience and now as a Deputy Director at Ghana Health Service, what do you see as barriers for research teams involving stakeholders from the community and also from those who are in programs? What do you see as the main barriers, and how can we overcome that?
Thank you very much. Like already we have said, the first barrier in the context of the community groups and the context of the implementers. It's an important part of how we scale up, because sometimes when we look at the cost of the implementation research and we try to multiply it across the country, the figure becomes so huge that it becomes a little difficult to quickly take it up. So it's the language and how we communicate various aspects of the research in terms of its the findings and all that. The second thing is, like I said, communication, I think, from the researchers, and therefore we need some common grounds of communication so that if there are some platforms where we meet and understand each other in terms of what we call, because sometimes at the policy level, we are using a different confidence interval of maybe 50%, and the researcher is using 95% to declare something good or bad. So sometimes what they declare good or bad, we may declare good because we think it's one. And not enough research is written in the form that the policymakers can comfortably read, because most of the time they don't have the time to read everything. But if a lot of policy briefs are done in a way that it becomes easy for us to summarize the easy, because most of the time when you are talking to the ministers and the political leaders, you may need to summarize it in a very, very good way. And I think the last one is how they relate to the relationships with the policymakers. I think these are very important aspects for how they relate to the policy, because if you relate to academic, then they think this one is academic, this one is policy, or this one is implementation, and they divide it and they never come together. Thank you very much, and over.
Okay, thank you, Dr. Andrews. I now turn to Dr. Matthias. Dr. Matthias, please, can you reflect on, from your viewpoint, what are the barriers for translating findings into action, especially in the context of community health?
Yeah, thank you, Prof. Alex. From my perception or my point of view, the barriers to translating findings into action is often related to the fact that, like what I was saying, that in most of the research activities, first stakeholders are not involved in a kind of like we do in the implementation, a kind of co-creation involving the process of identifying the real needs of assessment. So presenting just findings that are not related to needs sometimes make the different stakeholders not really interested in the results that are presented and are not, get ready to be involved in a kind of translating these findings into action. And the other barrier is related to sometimes financial issues, like Dr. Gumu was saying in his presentation. In our context, for instance, for the community health policy, we have this issue of budget, where sometimes even though we can have some recommendation from research and from research activities, translating this different recommendation into action is a bit difficult because we don't have a really funding strategies for, of our different policy, community health policy or different research, programs or projects that needs to turn this different research recommendation into action. Thank you. Over to you.
Okay, thank you very much, Dr. Matthias. I think we have no, I think we have no more question for our panelists. And so we are moving slowly toward the end of this this webinar. And I would like to take the opportunity to really thank our speakers, because they have been able to take us through all the steps from the design, the conception, co-conception of an implementation research to the implementation of the research, and also to the dissemination of findings, and how those findings are used and translated into policy and also into practice. And we have also gone through some field experience and see how implementation research can support improvement in the field, and also from a small experience, how it can support the extension from local to national level. So I want to thank our panelists. And we had today Dr. Gumu, who is working at the Ministry of Health in Guinea, Dr. Matthias Grovogi, who is a lead researcher in Guinea. We also had Dr. Andrew Zayim, Deputy Director, Ghana Health Service, Dr. Amafeni, lead researcher in Ghana, and Dr. Alphonse Zakpasu, who is a medical superintendent and implementer in Ghana. So I also want to thank all the participants for their patience. It was a long session. Also, thank you to the organizers of the 7th Global Symposium on Health System Research, in the framework of which we are holding this webinar. Thank you to the team of R4D and also Accelerator Project, and of course to all the partners that have supported this initiative. Again, thank you to USAID, Health Strategy and Delivery Foundation, ICF, Bill and Melinda Gates. I don't know if it's possible to get a family photo, if everyone can put on the video, And then we can have a kind of family photo that we can share with all the participants. Okay. Please don't be shy. Put on your video for the family photo. Okay. Great. So Kylie, I hope you can help us to take a very good photo. Or Ken, okay. Please tell me if you get the picture.
Mikam, are you able to
Yes,
take the
yes,
photo?
I got a photo. Thank you.
Okay. Okay, so thank you very much. Thank you to everyone. And I wish you all a nice afternoon or evening, wherever you are. It was nice having you. And we hope to meet again in another opportunity. Thank you very much.
Thank you.
Thank you. Thank you for hosting us.
Thank you.
Thank you, everyone.
Thank you so much.
Thank you.
I am broadcasting from the World Bank headquarters in Washington, DC. Yeah.